All right, let's talk about something that is, without a doubt, a massive shift in how we treat urothelial cancer. We're talking about a new first-line standard of care for our patients with locally advanced or metastatic disease. The data here, well, it's not just an update, it's a complete game changer.
So let's just cut straight to the chase, right? The bottom line is this. The combination of Enfortumab Vedotin and Pembrolizumab, what we're all calling EV+P, isn't just a step forward. It has, and I don't think this is an overstatement, completely revolutionized how we manage this disease. It is the new standard of care, period.
Okay, so here's how we're going to break this down. We'll look at why this is the new standard, diving into the landmark EV302 trial. Then we'll get into the mechanism of synergy, talk about navigating the safety profile, which is crucial, and finally touch on what's next. The new questions we have to answer.
All right, Section 1, the EV302 trial. This is really the proof behind this whole paradigm shift. For decades, platinum-based chemo has been our go-to. It was the undisputed champion. EV302 was the trial that asked the big question. Can EV+P finally take that crown?
And the answer was a resounding yes. I mean, look at these numbers. The median overall survival. It's just incredible. We're going from 16.1 months with chemotherapy to 31.5 months with EV+P. That's almost double. I mean, we just haven't seen a survival benefit like this in advanced urothelial cancer before. It's truly unprecedented. And if you want to boil it all down to one statistic, here it is. 53%. That's the reduction in the risk of death compared to chemo, a hazard ratio of 0.47. Numbers like that, they really don't need any extra commentary. They just speak for themselves. And it's not just about overall survival, right? The benefit is consistent across the board. Look at progression-free survival. Again, more than doubled. We're talking 12.5 months versus 6.3 months. So our patients aren't just living longer, they're living longer without their disease getting worse. That's a huge win. So let's just put all the key efficacy results side by side. You can see the story is just incredibly consistent. Median OS, we've covered that. Huge improvement. Median PFS, same story. But look at the response rates. The overall response rate jumps from about 44% to almost 68%. And for me, this is the kicker, the complete response rate. We're seeing almost 30% of patients achieving a CR. That's more than double what we saw with chemo. We're not just controlling the cancer, we're achieving really deep, durable responses in a significant number of patients. Okay, so the numbers are undeniable. The clinical benefit is crystal clear. The next logical question is, why? How does this actually work? Let's get into the science, the mechanism of synergy between this ADC and the PD-1 inhibitor. And this diagram really explains the elegant 1-2 punch beautifully. So step 1, Enfortumab Vedotin goes in. It acts like a guided missile, targeting Nectin-4, which is all over these urothelial cancer cells. It delivers its payload, MMA, and kills the cell. But here's the brilliant part. It doesn't just kill it quietly. It causes what we call immunogenic cell death. It's like setting off an alarm that screams danger to the immune system. This wakes up and activates T cells. And that's where step 2 comes in. Pembrolizumab takes the brakes off those newly activated T cells by blocking PD-1, letting them go after the tumor full force. It's a beautiful synergy. Now, as with any powerful new therapy, we have to talk about the other side of the coin, the safety profile. And this is really important, because the toxicities we see with EV+P are not the ones we're used to with classic chemo. Managing this well is absolutely key to keeping our patients on treatment. And here's the big shift in thinking for us clinicians. For so long, with chemo, we were laser-focused on myelosuppression, right? Anemia, neutropenia, watching the counts. Now we have to retrain our brains. The big three for severe AEs with EV+P are totally different. We're talking skin rashes, hyperglycemia, and peripheral neuropathy. It's a whole new playbook. Let's just drill down on these a little more because you're going to see them. Cutaneous reactions are incredibly common, happening in about 70% of patients. You have to be watching the skin. Same with peripheral neuropathy, affecting around 76%. This is a big one that often leads to dose changes. Then there's hyperglycemia. You've got to be monitoring blood sugar regularly. And of course, because we have Pembro on board, you always have to be vigilant for those classic immune-related AEs, like pneumonitis. I really want to zoom in on peripheral neuropathy for a second, because this is the toxicity that's most likely to make us stop treatment. It's coming from the MMAE part of the EV. A key thing to remember is the timing. It often doesn't show up right away. The median time to a grade 2 or higher neuropathy is about 6 months, so you need to keep asking about it. And we really need to set expectations with our patients.
the recovery can be very slow. One analysis showed only about 13% had a complete resolution, so getting ahead of it, managing it proactively, is just critical.
So, we've established this new standard of care, which is fantastic. But as always in oncology, a great answer just leads to a new set of really interesting questions. We've solved the first-line problem, and in doing so, we've completely changed the map for treating urothelial cancer.
And this, right here, is the million-dollar question for all of us in the field now. With EV+P firmly in the front line, what do we do second line? Think about it. All our usual second and third line options have either been used or might be less effective. We now have a brand new patient population, those who have progressed after EV+P. Figuring out what's next for them, that's the next great challenge. So this isn't the end of the story. It's really just the beginning of a whole new chapter.